new approach to cough and or the annoying cough that does not go away. So I think most people can probably understand the frustration of a cough and the difficulty with controlling a cough. And Ali and Sheeta will go through the reasons, the medical reasons, and also the cough control therapies that are available to try and help you control your annoying cough. And at Lung and Sleep, our aim by doing all of this is really to try and help and inspire as many people as possible to improve their health. So from here, Dr. Sheetal Deshpande, I'm going to hand over to you in just a moment, who is going to talk about what is cough, the medical causes of cough, and the medical management of cough. And then we will have Ali, who is going to go on and talk about cough control therapy.
Great. Okay. Thanks so much for joining us tonight, everyone. Really good to see so many of you join us. Like Leah said, I am one of the respiratory physicians here at Lung and Sleep, and I can see some familiar names and faces amongst the Zoom crowd, I guess, as you will. So today we're talking about a really common presenting complaint, the cough. So we'll be running through, the definition of a cough, the investigations that we go through and the possible treatment options, and then running through some of the common causes of a cough. And then ultimately also what we do when your cough just keeps going. So let's start by talking about what a cough is. A cough is an important reflex that's essentially part of our immune system. It helps to protect your airways and your lungs, and it can be triggered by various factors such as dust, smoke, pollen, medications, or even having underlying lung disease like asthma or COPD. This is a diagram of the cough reflex arc. So essentially your throat and airways are aligned with cough receptors, as well as a thin layer of mucus which coats and protects your airways. When you are breathing, you can inhale some of these foreign particles, like we mentioned, the smoke or dust, even perfume, which can irritate the airways, and these particles can get stuck in the mucus lining your airways. The cough receptors in the airways then signal your brain, which to tell them that there's a foreign intruder in the lungs, and then the brain sends a signal back quickly to the chest wall and abdominal muscles to rapidly and forcefully get you to take a deep breath in order to expel the particle or the trigger, remove the trigger. So that's where that cough comes from. So, an occasional cough is normal. It's a healthy function of your body and important to clear any foreign invaders that come into your lungs. But when a cough becomes persistent, that's when it becomes abnormal. Coughs that persist can be classified as acute, subacute, or chronic, depending on how long they last. So an acute cough is one that would last less than 3 weeks, and most commonly this will be caused by an infection, either viral or bacterial. If a cough lingers, however, for greater than 8 weeks, that is when we classify it as a chronic cough, and it is certainly one that you should seek medical advice for, either by seeing your GP or coming to see a lung specialist. So when someone does present with a cough, our aim is to find the cause and exclude any of the sinister causes. We then work to find a treatment that is effective for treating your symptoms, or in the case where no cause of the cough is found, or if it's due to chronic lung disease, then we have to find ways to manage your symptoms. So there are various investigations available when someone presents with a cough, and we work our way through these systematically. Now, everyone who comes in with a chronic cough should have 2 basic tests, one being a chest X-ray to give us an idea of what your lungs look like and to look for any obvious causes, and also breathing tests, which show us how well your lungs are working, the volume and the flow capacity that they have, as well as how efficient they are in gas exchange. And many of you may have met Kyle in our Bentley rooms performing some lung function there. So depending on your symptoms and our clinical suspicion, we may then go on to do further investigations, which I've listed in the middle here. So asthma is one of the main causes of a cough, and normal lung function doesn't always rule out asthma. So we may go on to recommend what we call a bronchial provocation test. This is where we get you to inhale irritating substance to the lungs, but only irritating if you actually have asthma. Some people may require a CT test, which gives us more detailed imaging of the lungs. And this is often something that we would do in people who are smokers or people at risk of chronic lung disease. Sleep apnea is often a cause of cough that's overlooked. However, a sleep study can help us to investigate this as a cause. And as Leah showed you before, there's Barton in his sleep gear. So another test that we may undertake, which is a little bit more invasive, is a bronchoscopy, which is essentially a camera test where we look down into the airways and obtain samples from the lungs to look for signs of infection or other lung disease. And cough can often also be caused by sinus or upper airways disease. And in that case, we may refer you to an ENT specialist or an ear, nose and throat specialist to have a look down your nose. Sometimes even before proceeding with some of these more invasive investigations, we can often recommend what we refer to as empiric therapy. Now, empirical therapy refers to a trial of treatment without actually having confirmed a diagnosis or a cause of your cough. We often tailor this according to your symptoms and the history that we get from you and what we think the most likely cause is. So if the symptoms are suggestive of sinus disease, then steroid nasal sprays are often recommended. Inhalers, if there's suggestion of inflammation or asthma in the lungs, a trial of anti-reflux medications, antibiotics for infection, or prednisolone, even if we think that there is inflammation that could be contributing to your cough. So what we should talk about next is, of course, the causes of a chronic cough. There's quite a long list here, and I've listed the more common causes on the left and the less common ones on the right. Infection is a really common cause of cough, and as I mentioned earlier, it's often the cause of an acute cough. Sometimes it can linger and cause a chronic cough. However, often it causes residual inflammation, which causes that persistent cough, so what we call a post-viral or post-infectious cough. The other common causes of chronic cough include asthma, reflux, upper airway cough syndrome, and sleep apnea. And I'll talk about those in a bit more detail in a minute. So chronic lung disease is often one that patients are concerned about, and these include things like COPD, lung fibrosis, or bronchiectasis. And these can all cause a chronic cough, which even with management of the lung disease, for example, with inhalers, may not completely resolve. Lung cancer, of course, is another cause of cough that is worrisome to many people. This is actually a relatively uncommon cause of a cough, and we do investigate for this depending on the smoking history, and whether you have symptoms such as coughing up blood or unexplained weight loss, then we may be more likely to be suspicious of a diagnosis like lung cancer. But overall, it's not the most common cause of a cough. So now I just wanted to go through in a little bit more detail the more common causes of a cough. So asthma is one of the #1 causes of a cough. People often associate asthma with symptoms of breathlessness, wheeze, or chest tightness. However, there is a type of asthma called cough-bearing asthma that can present with only a cough. As I mentioned before, lung function tests can be normal, so you may go on to have a bronchial provocation test. And once the diagnosis is confirmed, or even if there's a high clinical suspicion, we might commence you on inhalers, Ventolin, or things like Symbicort or Seretide to help treat the asthma. So another really common cause is the upper airway cough syndrome, which is essentially caused by upper airway and sinus inflammation. It leads to symptoms such as postnasal drip, constant clearing of the throat due to a feeling of mucus or sputum being stuck in your throat. And your symptoms are often worse at night or first thing in the morning. Now, often we will commence a trial of an intranasal steroid before going on to do other investigations, because this cough is often very responsive to nasal sprays like Nasonex or Demister. But however, if the symptoms are resistant, then we may do a CT of the sinuses or refer you on to the ear, nose and throat specialist. Now, reflux is a really common cause of cough, and this can be due to microaspiration of acid from the stomach into the lungs. That, of course, causes irritation of the upper airways and the airways and inflammation, which then results in a cough. Sometimes people with reflux present solely with a cough and don't necessarily have symptoms of indigestion or heartburn. Sometimes we see a hiatus hernia on imaging, and this can increase our clinical suspicion of reflux, and we may trial you on a course of a anti-reflux or anti-acid tablet. Now, like I mentioned before, sleep apnea is a cause of cough that can often be missed or overlooked. 30% of patients with sleep apnea have a chronic cough, and they present with symptoms of cough, but also with snoring and sleepiness. And so a sleep study is a relatively straightforward test that we can order, and CPAP often significantly helps those symptoms of cough. So when we've completed the necessary investigations and trialed various treatments, but we can't pinpoint the exact cause, or your symptoms aren't responsive to treatment, or even if you've been diagnosed with chronic lung disease, but your cough continues to be an issue, that's when we refer you on to our respiratory physiotherapist colleagues for cough control therapy. Now, this is an effective way to manage your cough and is certainly really useful to a lot of patients. So in summary, I just wanted to highlight that, a cough is a really common symptom. Our aim is to rule out any underlying lung disease and to rule out the sinister causes, and then work our way through common therapies to try and address the symptoms. Invasive investigations are then used to rule out any other causes. However, if we aren't able to find a specific cause, or if your cough just continues to linger, then we refer you on for cough control therapy. So now I'm going to hand over to one of our lovely respiratory physiotherapists, Ali, to talk to you more about cough control therapy.
Thank you for joining us today again. And I'm Ali Kavanagh, and I'm so pleased to have met some of you who have showed up here tonight. Thank you very much, and look forward to, I'm sure I'll be meeting a few more of you in days and weeks to come. And I hope you find today's help really helpful. Today's talk really helpful. Tongue-tied. Okay, I think a good place to start would be to once again define the type of cough that we will be mainly addressing tonight, and that is known as refractory chronic cough. So this is cough that has been going on for more than 8 weeks, and it's not mainly accounted for by any significant underlying lung disease. Some of the common triggers for this type of cough would include temperature changes, sensitivity to acidity. So if you eat something peppery or with chili, sensitivity to fumes, scents, smoke, dust, and also can be triggered quite commonly by talking, so speech. What we know now is that this problem comes about from a hypersensitivity and a hyperresponsiveness of the cough reflex. So that neurological reflex pathway that Dr. Sheetal was talking about in her previous in the previous slides. So what that means is that, if everyone can see my cursor, people who have chronic refractory cough, they have a lower threshold for a stimulus to trigger a cough compared to normal adults. But in addition, the amount of coughing or the response to a trigger is much greater than what would happen in normal adults. So there is a loss of control in the mechanism of this cough. Of interest to note here, though, is that yes, cough is a reflex, but we all know that cough can be voluntarily forced and also voluntarily suppressed. So therein really lies the key to cough control therapy as well. I think it's also interesting to make you aware that this type of refractory chronic cough can overlay or coexist with genuine, true cough that arises from organic airway disease as well. So both more than one type of cough can exist in the same person, and it's really important that we are able to assess for that and appropriately treat, so in order to achieve outcomes. Because it will be logical for me to say, if you don't pair the right treatment with the right cause, you're not going to get the outcomes that you want. Okay, so what can we do about this type of cough? Well, unfortunately, there is no current available medication that is effective for it. There has been some response from neuromodular medications, but these also do come with the risk of side effects. However, the research has found robust evidence for cough control therapy, and here's the kick, when performed by a trained therapist. So both the European Respiratory Society and the American College of Chest Physicians are unanimous in recommending cough control therapy for refractory chronic cough. Okay, what the studies found was an improvement not just in cough measures. It also found that it could enhance benefits from neuromodulating medicines if you are on them. But ultimately, I think what's most meaningful to patients is that it improves your quality of life. So before we delve into cough control therapy, it is a prerequisite that we treat other existing organic causes of cough. So in our clinic for physiotherapists, we most commonly come across two causes that we would have to address first. These are not all the causes, but the most common ones would be sinus secretions and phlegm arising from the chest. So with sinus secretions, I know Dr. Cheetle spoke about them briefly before, but I have often encountered people where I would say, well, do you have, any sinus issues? No runny nose, no blocked nose. Do you have tenderness around the cheekbones? Is your brow line sore? Do you have a frontal headache? Do you have blocked ears? Oh, yes. So, an absence of runny or blocked nose is not the only sign of, no issues with sinus conditions, but we are also looking for signs of sinus congestion. So often our management would involve a two-pronged approach. One, to address any congestion that's already set in with your sinuses, but then also, like Dr. Sheetal talked about, often looking at, sinus rinsing to flush out that congestion sometimes, and then treating the inflammation that causes those underlying secretions to get that under control, often using a nasal spray. So, there will be a range of nasal sprays there on the market, and we always collaborate with your medical practitioners to work out which would be the one that would be best suited for you. So the second most common cause of organic cough would be phlegm arising from the lungs. There are a range of what we call productive lung conditions that would produce phlegm in your lungs. And if we do not appropriately address that and jump to trying to suppress cough, we will actually be trying to stop your body from getting rid of something that could cause further harm, and we don't want to do that. So this is the tip of the iceberg, a host of mucus clearance techniques, some involving devices and others not involving devices that are out there. And our advice to you today is that you again work with a trained therapist that would be able to select the most appropriate technique that suits your lung airways, your lifestyle, and would achieve the effects that you want from mucus clearance techniques. Okay, so once we adequately address, cough due to true organic causes, then any residual troublesome cough can be addressed through cough control therapy. So cough control therapy, that involves 4 main components. The first, beginning with developing an understanding and an awareness of your cough. So understanding how your cough works, understanding how it behaves, learning about what are the triggers, how does it change across the day, across the seasons. And the more intuitive awareness we can develop, the easier and the stronger the conscious control we can develop together over this irritating chronic cough. Okay, so it begins with understanding and awareness. The second component being looking at airway care. So this even comes right down to hydration, because if your hydration levels are not adequate, a dry airway can produce more secretions and is more easily irritated, triggering and subsequently will trigger more coughing as well. We look at your lifestyle and whether there's any exposure to irritants and how we can minimize that to reduce the trigger exposure that causes your cough. The third component is quite a significant one, breathing retraining. So breathing retraining often would involve harnessing the efficiency and the power of the diaphragm to dominate most of your everyday breathing. And if we can get your diaphragm to work as strongly and as efficiently as possible, then there's going to be less reliance on your upper chest and your upper airway to contribute to everyday breathing. So when we can take some tension away from that throat area, we can relax it, we can open up the airway, it's going to be much less irritated and much less likely to give in to cough. This component is especially important for people who have some vocal cord dysfunction, or where just with the way that we're born and we've developed, some people do have airways that can narrow or close a little bit earlier than desired when they breathe in and out. So breathing retraining is also quite often a significant component of cough control therapy. At Lung Life, we are certified Bradcliffe breathing practitioners. So that's the breathing retraining method that we specialize in, but we also acknowledge that that's not the only breathing retraining method out there. And finally, the fourth component being the mastery of cough suppression or cough substitution techniques. But you can see that, along this whole journey, it is underpinned by education, and more education. So we are talking about rewiring a neurological reflex pathway. Okay, so the aim of cough suppression is to de-escalate overactive neural pathways and strengthen your conscious control over cough. So you can imagine that this is going to take practice, commitment, and time. Often people who have arrived at our services and have this need have been through a whole series of medical examinations and investigations, which are all really important to identify or exclude organic causes of cough. And so we understand that it can be quite a frustrating and also quite an emotional journey to get to this point. And when they arrive, to our rooms, it can be hard hearing that this is not just going to be a silver bullet handed to you or a pill that you can take and it will change your life. It's going to be a process that will still change your life for the better. But it does take time. So what underpins the strengthening of this and the development of this conscious control over cough is the awareness, knowing that the urge to cough is real. The triggers to cough are real. That sensation, that irritation is real. But the need for the cough is not real. The need for the cough is not real. And it's really important that our patients feel empowered with that to then develop the strategies and the skills they need to get this cough under control and effectively managed. So we talked about learning a lot about the behavior of your cough, because that is the key for us to be able to tailor strategies to your needs and the behavior of your cough. So in the bottom left corner of the screen, you would see I've just listed, not a comprehensive list, but some of the common cough suppression strategies that we use. And often it's not just one strategy for an individual, it would be a combination of strategies. So I'm going to get some action happening here and ask you to follow me through some of these steps. So we're not going to do water sips, but you would know what they are. I'm going to get you to practice a dry swallow versus a hard swallow. So a dry swallow is just a normal swallow that looks like this. And now try 2 hard swallows. As hard as you can. Keep your lips together. Rest your tongue on the back of your top teeth. And tune your focus to that stream of air flowing in and out through your nostrils. Notice how the back of your throat is relaxed and open, and your throat is relaxed. Sometimes we also employ other breathing techniques, especially when there can be some other conditions involved. So I mentioned vocal cord dysfunction before. That's where the vocal cords abnormally come together when they shouldn't. So they cause an occlusion in the airway. Pursed lip breathing can be very useful for that. It helps to split open the airways. And again, we're trying to relax and remove tension from that upper airway that can fuel more of this type of cough. Sometimes I will say to my patients, if all else fails and you cannot get rid of that urge to cough, you can try what we call a huff. So that would enable, especially for people who feel that, the trigger is that they feel something sort of stuck in your throat, or there's something there that needs to be coughed up. They can do a huff. So it's a rounded shaped airway from your mouth right down to your throat. And what the huff does is it produces enough flow to dislodge anything that might be there, but it doesn't allow for the contact and the trauma of your airways banging together, which can then cause more swelling, more irritation, and more secretions in the upper airway that leads to more coughing. So these are just an idea of some of the strategies that we would use quite commonly. So with cough control, we always start with the smaller coughs. So one thing we get to do is to get you to learn about how strong the urge to cough is for different coughs, and we get you to start targeting the lesser urges to cough. Once we gain mastery over those coughs, that skill can slowly be built up and strengthened. We can start to wean some of the strategies required, and so that you can tackle the bigger coughs. And I think for me, from experience, it's quite often that when you start to develop this skill, even the urge, the frequency of the urge to cough itself starts to reduce quite significantly. Okay. So yes, you can already appreciate that, yes, there is effort and there is time, the cost of your effort and your time, and yes, healthcare costs as well, for addressing this type of cough through cough control therapy. But I do want you to consider as well the cost of coughing itself. We know that cough is not just a physical burden. It's not just a physical respiratory burden, but chronic coughing can also result in incontinence, so a loss of control of urine, wind. It can affect your sleep, especially if you are coughing so much that you're waking up in the mornings with headaches, coughing till you dry reach or vomit at times. You can also have cough syncope, so feeling faint or actually fainting from so much coughing. Socially, talk about embarrassment in this day and age, right? It can be an annoyance to others, but also chronic coughing interferes with your conversations to your loved ones, socializing, and your ability to work. So financially, some people have suffered a loss of work, but also then have to, the amount of money that they are putting to find a solution to this problem as well. It probably does not come as a surprise that chronic cough, in the research has also been associated with greater levels of, anxiety, and especially anxiety about, undetected underlying illness, feelings of isolation, and depressive symptoms as well. So don't want to end on a bad note, but weighing up, the cost of an effective cough control therapy with the cost of coughing. I'll leave that with you. So in summary, our take-home message for you is that cough can be successfully managed with your medical practitioners, but also with trained therapists. Yes, you do have to undergo the relevant medical examinations to identify or exclude organic causes, but making sure that when you are ready to get help, that you do work with a trained therapist. So I will leave it at that and pass it back to Leah to carry on with our session. Thank you for listening.
Thank you very much, Ali. That was fabulous. And thank you, Sheetal. I think that there was lots and lots of great information there that hopefully is really useful to people. I'd like to open the floor if anyone has any questions, and we'd love you to ask a few questions if you're happy to pop them into the chat, and I will go through them and try and get the right people to answer them for you. So we might just start with Sonia has asked, Ali, can you just explain the dry and hard swallow again?
Yeah, sure. So a dry swallow is basically just a normal swallow. You're not ingesting any liquid or food, so literally a dry swallow. A hard swallow is where you swallow with force. Now, choosing, between the two techniques, again, it comes down to the individual, which your therapist would work with you to work out which, what can be helpful, because sometimes too much hard swallowing can actually become irritating for the throat and then not be helpful for the cough. So I hope that answers your question.
Penelope has just asked Ali or Sheetal, is there a role for cough suppressant therapy? And I'm guessing, are you referring to cough suppressants that you would purchase, Penelope? Or feel free to unmute yourself and ask if you would like, or...
Yes, in terms of the individual trying to get to sleep at night, is there a role for medications such as Vicodin, etc.?
Yeah, Sheetal or Ali, would you like to answer there?
I think the evidence for medications for cough is generally short-term use. We don't generally recommend them in the long term. And also it's important that we've ruled out any underlying cause for the cough, because if you're suppressing, for example, a cough that's due to a chronic infection or due to build-up of mucus, and that can lead to more problems than, benefit, I suppose, in the long term. So really, we'd only recommend medication like, codeine or those sorts of things just for short-term use.
Ali, Ronnie has just asked in regards to, I guess, the exercise journey or the cough control therapy journey, and how long does that really go on for? And is there light at the end of the tunnel, or is it really about managing cough to not be as stubborn? I think it's a great question.
It is a great question. For me, touch wood, so far, many of my clients, so most of my clients actually, have experienced almost, immediate benefits. I'm talking after one session. I think the important thing to know about this rehabilitation journey is that a small change can make a huge difference to the quality of your life. A small change can make a big difference to how your day goes and how interrupting, cough can be. I would say that the duration of the journey varies for everyone, depending on also if we're talking about solely refractory chronic cough, it can range from a week through to a few months. If they've got cough that is due to a number of reasons, so like I talked about before, there can be cough because of phlegm or secretions that are particularly stubborn, and then an element of hypersensitive cough over that is a bit more complicated. So yes, there is light at the end of the tunnel. It doesn't take much to get some significant benefits for yourself, benefits that are meaningful to yourself. So yes, I would say it's worth. We need a patient testimony, I think.
And I guess from the perspective of Barton and I, we would just love you, if you really enjoyed this evening, please recommend it to other people. We would love to continue to bring more people on board and pass out the information that you want to hear. And alternatively, we'd also love you to tell your GP about it. We also have GP specialised evenings, so there is one next week. So if you've really enjoyed it and you think your GP might, please ask them to come along to our particular GP events. But again, on behalf of Lung Sleep, we are really, really grateful, and I hope that you are all enjoying a little bit more freedom in the next few weeks. Have a lovely, lovely Christmas, and we hope to see you all again early next year for our first event. Give us some ideas of anything you would like to hear about. We'd love to know.